Okay, so welcome everybody. It's my pleasure to welcome you all to today's Dean's Lecture. My name is Catherine Clegg-Smith, and I'm the Vice Dean for Faculty at the Johns Hopkins Bloomberg School of Public Health. And I'm so honored to be here today on behalf of Dean Ellen McKenzie to introduce today's speaker. Before I do, I'd like to recognize what brings us here today. The Dean's Lecture Series provides us with the opportunity to highlight the work of our newly appointed and promoted professors, as well as our senior scientists. These lectures are a chance to hear from esteemed colleagues who are leaders in their fields and who are impacting lives through their research, practice, and teaching of public health. And so today, I'm so pleased to welcome Professor Michele Decker, a renowned expert on social determinants of women's health and gender equity. She has dedicated her career to understanding and preventing gender-based violence and advancing women's health and equity around the world. Professor Decker is a professor in the Department of Population, Family, and Reproductive Health, and she has a joint appointment in the School of Nursing. She also holds an endowed Bloomberg Professorship of American Health, where she directs the Violence Steering Committee, and she also directs the Women's Health and Rights Program at the Center for Public Health and Human Rights, and she served as a co-leader for Gender Equity and Justice Group at the Johns Hopkins Alliance for a Healthier World, forming the basis for a newly developing initiative on global gender equity. And in addition to all of this, she's also the co-leader of our university's Sexual Violence Advisory Committee to the Provost. And we're so very grateful, Michele, for all of this service and work that you do. A social epidemiologist by training, Dr. Decker is advancing the understanding and prevention of sexual assault and intimate partner violence. Her work is truly global, from right here in Baltimore to field sites in East Africa and beyond. Much of her work is focused on marginalized populations, including adolescents, urban women, and those involved in transactional sex or sex work. From advancing clinic and community-based interventions to studying how violence impacts reproductive health, Professor Decker has expanded our knowledge of sexual and reproductive health while fighting to protect the health and lives of vulnerable groups. In all of these efforts, she applies a trauma-informed lens, paying close attention to the ethics of performing research on sensitive topics. Her work is complex and far-reaching. To give just a few examples, in partnership with the House of Ruth Maryland and with support from the National Institutes of Justice, Michele and her colleagues conducted a study showing safe, affordable housing is a powerful tool for preventing intimate partner violence. And now they're planning to use those findings to scale up their efforts to make an even greater impact. In cooperation with the CDC and state organizations, her latest work is advancing our understanding of how social and physical environments shape sexual violence, risk perception, and experiences on college campuses through an innovative application of hotspot mapping. And working with PMA, which as many of you know is a powerful data platform, she's studying trajectories of gender-based violence and other gendered impacts of COVID-19 among adolescents and young adults in Kenya. This work has revealed endemic gender disparities in this setting, in addition to the risks that were amplified during the pandemic. So, as you can see, Professor Decker is making an impact that's felt both right here at home and around the world. And collaboration is a hallmark of her work. She forms connections across our institution and beyond to undertake these critical projects. Her colleagues know her as a creative thinker, a problem solver, and a great listener. She's also a sought-after mentor. Michele will tell you that seeing her students and practitioner partners succeed and carry the work forward in their field is among her proudest achievements. Professor Decker brings exceptional drive, ambition, and compassion to her work. In fact, her motivation to study public health began when she was serving as an advocate for victims of sexual violence. She answered hotline calls. She accompanied people in the emergency room. She saw the impact of violence firsthand. Those experiences inspired her to pursue a career in public health because she saw it as a clear path to lifting stigma and speaking out for evidence-based solutions. And through it all, she stayed close to those who perform frontline service, and the lived experiences of victims continues to inform her work. Gender-based violence, unfortunately, is a pervasive issue that's too often silenced. It's a topic that many people turn away from because they feel it's too uncomfortable or the work is too intense. But Michele has always felt drawn towards it. And through her determination and conviction, she's helping build a safer and equitable world. As I know Dr. Decker will tell you today, she believes we are moving into a new era of prevention and response on gender-based violence. We have elevated the rigor of the science, and we know what works. We're on the path to a better future, and Dr. Decker is helping us get there and training the new generation of public health leaders to do the same. Professor Decker, Michele, welcome. We're so very excited to hear from you.
Thank you. Wow, welcome everyone. Thank you so much for that incredible introduction. And Kate, I'm just thrilled to be able to be here with you today. And thanks to our Dean, Ellen McKenzie, to our chair, Cynthia Minkovich, and I'm just thrilled to see so many collaborators and colleagues and trainees, both in our on-site experience, and I'm seeing so many friends and collaborators joining online too. So hearty welcome to our colleagues online as well. All right, so here we are today talking about gender-based violence prevention and response. And I can't see my slides, but I know they're up there. Here we go. All right, good. So as many of you know, this is a long-standing health and human rights issue. It is a leading social justice issue for our day. And what we are going to talk about for the next 45 minutes or so, half an hour or so, is really about where we've been and where we're going, and why is there a renewed attention to GBV today. What is it building upon, and really where are we going in the future? Where do we need to be positioned for better forms of prevention and response and truly gender equity in this space? So this is a really exciting time for the tools of public health, specifically on this topic. So let's back up. Here we are on International Women's Day. Let's back up and really think about a gender equity frame and a global women's health frame so that we can really position the work on gender-based violence within this broader sphere. So when we think about gender inequities, we're really talking very often about gendered systems and their influences using our socio-ecological model. So we see things at the macro policy level, discriminatory pay, discriminatory policy, as well as macro practices. So when we think about inheritance rights, whether there's a policy prohibiting it or a macro system prohibiting it, right? When we think about women's control over assets that they may have inherited or earned, these are restrictions at the social macro level, whether they're social or policy. We also see these elements at the social and normative level that are very, very influential in terms of people's behavior and how they understand their roles and work and live within those roles in our communities. We absolutely are going to be talking today primarily about the interpersonal level, the relationship dyad, and the family structures that are related, and where similarly we see gendered power imbalances that continue to shape risk, certainly for violence in other domains of gender inequity. And this is all layered, of course, onto our individual factors. We talk in our women's health training here at the school a lot about the ways in which the social side, the social gender systems, interface with sex differences and the biology side of things. And so I just offer you, for folks that are interested in this space, I really offer you this incredible framework that came to us from the Lancet Commission just a few years ago, led by Lori Heisey and a fantastic team, showing the interaction and accumulation of the biology features, the systemic gender structures, positionality, age, class, ability, race, ethnicity, and then how those influence our systems moving forward over time. So certainly today, we're going to be focusing in very specifically on GBV, but really wanted you to have this broader framework in mind when we think about gender equity. So let's turn to the issue of gender-based violence. This really affects 1 in 3 women, an estimated 1 in 3 women across her lifetime. Leading forms of GBV are intimate partner violence and sexual violence from partners and also non-partners. So there's some of our leading forms of GBV, and we'll talk a little bit about some of the others that have emerged and have gotten a little bit more clarity over the past several decades. What's really important to know about this is that while GBV affects people across the gender spectrum, we continue to see very persistent disparities in prevalence, in severity, and in impact in a way that really undermines women specifically and compromises health and human rights specifically for women. So the example that you see both on the map and right up here is that intimate partner violence homicide is responsible for just about 13% of homicides globally when we group men and women together. When we're looking at women's homicides alone, it is 38% globally. And this is likely an underestimate. For those of you that work in global spaces, you know that the registration systems and the death counting is often really a lot less precise than we'd like it to be. So when we think about what's driving women's morbidity and mortality, preventable mortality, this is really a leading cause and a leading issue specifically for women. And while we see this and talk about it really at the interpersonal dyad level, that interpersonal level, it's important for us to know and understand that this is really shaped by that full socioecologic system. And we're going to unpack that a little bit further today. So let's take a little bit of a look back in time to understand where we are and where we're going and appreciate some of the roots in this space and the gains that have been made in the past 20 to 30 years. I'm going to take us back to the 1990s. Trainees from our GBV course know that this was a watershed time period for women's health and human rights, and certainly for GBV. In 1993, we saw the United Nations Declaration Against Violence Against Women. Right here in the United States in 1994, we saw the passage of the Violence Against Women Act, landmark federal legislation. And then the image that you see here, we didn't do a great job branding things in the 90s apparently, but this is from the fourth World Congress on Women that gave rise to the Beijing platform, the Beijing Declaration and Platform for Action. And this was so groundbreaking, sweeping recommendations and recognition of gender inequities across economic, home life, political spaces, and really lifted up GBV as specifically a key issue for global gender equity. So one of the recommendations, so how does evidence in action works in synergy? One of the recommendations that came out of the Beijing platform was a call for higher quality data. At this time, we did not have the DHS systems that we have today. We did not have the surveillance in place. In fact, if anything, it was sort of like, we can't really ask about violence. We kind of know it's happening, but that's in the home and we really can't do anything about it. So one of the things that came out of this was a call for research, and the WHO took this up and successfully fundraised and implemented the WHO multi-country study, the first cross-national systematic examination of the prevalence and the nature of violence against women. In order to do that, we needed better measurement systems and we needed an ethics framework so that we could do this without harming people and also ensuring that people get connected to care and support services. So this gave rise to, this platform really gave rise to just a skyrocketing of publications and nations for which we had data. And that's the graphic that you see here. Some colleagues undertook a wonderful bibliographic review and showed just how this has accelerated. Our knowledge has really accelerated over time. And what has that allowed us to do today? For folks that are familiar with the Sustainable Development Goals, you know that number 5 is really focused on gender equity and empowerment of women and girls. GBV prevention and response is one of the key indicators within that. How did we get there? It was thanks to the data and the lift on documenting the prevalence and the nature, the unmet needs, and some of the concerns, and really, really getting this evidence base on the map. All right, so that's a little bit of my entree as well into this space, is coming into this work shortly after those really landmark elements, and really starting to do this work on prevalence and health impact of violence for women and girls across the lifespan. One of the places that we really leaned into was in the area of sexual and reproductive health. And I've given you just a couple of examples around the disparities. Some of these are from the Youth Risk Behavior Survey. Looking at teen dating violence experiences, women were much more likely to also report pregnancy. We're talking about high school youth, as well as an STI or HIV diagnosis. There were gaps and disparities as well on contraceptive use, and you see some issues here for IPV survivors being much more likely to report issues around successfully enacting, in this case, condom use, fear of asking for condoms, and inability to refuse sex. So we're really seeing this synergy on violence and power imbalances and how it is impacting sexual and reproductive health. At the time, the current thinking was sort of like, well, it's really hard to adhere to oral contraceptives if you've got kind of a lot going on in your life, right? One of the big important stages and innovations, I think, that came out of some of this work was a recognition of a concept that many of you in this room are familiar with around reproductive coercion. Really a key link from gender-based violence, physical and sexual violence, to reproductive health. So we heard through qualitative interviews with adolescent girls, with adult women, that not only were they experiencing physical and sexual violence, but their partners were actually very specific about their pregnancy intentions for those relationships. Birth control sabotage, efforts to promote pregnancy, interfere with clinic visits, flushing oral contraceptives down the toilet, removal of implants, and other pregnancy prevention tactics. And so this was really surprising, I think, especially to our colleagues in reproductive health when we started really hearing about this. And you see an example here from one of our early interviews with adolescents about negotiations over contraceptive use. Then these arguments got too intense. This young woman wound up becoming pregnant as a result of this relationship and then underwent pressure for an abortion also in the same relationship. So really, these are not sort of completely separate spheres of women's lives, but actually very much one and the same. And I've highlighted here, one of the things that has been most exciting and rewarding in my time at Hopkins has been just the richness of the work that has grown out of this space, led by incredible colleagues, Sharvon Holliday, Shannon Wood with the global work, Kamala Alexander at the School of Nursing, again, really looking at some of the disparities in this space. And postdoc alum Karen Grace, who is now really heading up this work, focusing specifically on Latina health. And what do these disparities look like in this area? So we've also been able to build the global knowledge base on this topic in thanks to and in partnership with the PMA platform. And Shannon Wood has really led this work in terms of really understanding where in the world are we seeing this global phenomenon and how can we start to quantify it and operationalize it so that our colleagues in family planning can be working on it, so that our ministry collaborators can be working on this as well. And so you see here, cross-site, this is in a range of settings, past year experiences of reproductive coercion. Prevalence really varies, but in every site it was assessed, we saw some indication and some signal on this. And you see very similar findings in our Nairobi site to what we saw in Boston and some of the original work in this area. So this is really important because we want to understand how does violence impact subsequent health outcomes, and also what can we do to prevent it? Who is in a position to enact change and policy and practice to improve these outcomes? So what else have we learned in this time? And then we're going to segue into prevention and response. One of the things that has been most exciting, again, with these advances in the quality of data, is our ability to understand how specifically violence experiences accumulate and interact and create onward risk. So this was an opportunity that we had right here at Hopkins with the Women's Interagency HIV study, with some support from NIDA, to really understand at baseline, when women are coming into this extremely long-standing cohort study, asking about sexual risk behavior, all kinds of social determinants of health, we saw as well within this cohort that when women were coming in their baseline visit, their experiences of violence were fairly extensive. At the time, the thinking around risk was often really focused on childhood sexual abuse experiences and how that could create onward risk. What was really surprising, I think, to many when we dove into this cohort was that yes, there was a lot of sexual abuses in childhood, but then once we got into adolescence and adulthood, you're seeing a lot of intimate partner violence as well as non-partner sexual violence. So and you see those overlap in those Venn diagrams. So we know that these experiences are really layering, creating risk for women. One thing we were able to do in this cohort study is begin to fill the gap in prospective work on what predicts incident violence. We can look backwards or cross-sectionally, but one of the innovations we've seen over the past several years is, again, around incident. And what we see here is a dose response in experiences of baseline violence, creating risk for onward incident abuse experiences. So when we think about it, perhaps it's not that surprising. These can be chronic experiences, but when we document it in this way and really interrogate the data in this way, we understand that our mandate and our mission in public health is not only primary prevention, it's interruption, it's support services, and it's making sure that if we can't fully primary prevent, we can intervene early. And you see this dose response relationship as well. Folks that were coming in with partner violence experiences as well as non-partner violence experiences, much more likely to continue to accrue that risk over time. So again, really honing our need and our mandate in public health on really stepping up our game on early intervention as well. So I'm going to turn now to women that trade sex as a high risk and underserved population. When I was serving as a sexual violence victim advocate, fielding hotline calls, serving in emergency departments, supporting people making police reports, one of the things that became abundantly clear to me was the risk and the added stigma and shame and the complexity of the experiences for women that had come in our doors with a history or actively working in the sex industry in some capacity. So we've been able to really build this work out here in my time at Hopkins in collaboration with a number of incredible partners, many of whom are on the Zoom line today. And what we've learned in this work and what we've been able to really document in collaboration with human rights organizations and CBOs, folks that are really working on the ground in this space, is that this is a very high-risk population for violence, and their portfolios and profiles are very complicated. So yes, to police violence, certainly, partner violence. Women are also experiencing client violence in this space, and others that might be involved in the sex industry or in the adjacent drug industry. One of the other elements of this is the criminalization of sex work, which allows this violence to go on with impunity. So women that experience violence in these situations are not seen as victims, they're seen as perpetrators of a crime because sex work is criminalized. So that's been a big problem for prevention and survivor support. When we look out at our socioecologic model as well, we see that there are unique elements of shame, stigma, and blame in this population, the shaming of women's sexuality, the shaming of these experiences. And it's external, but by the time often they get into our studies and also through our doors on hotlines, it's internalized. So this is a really important action point for us in the space of public health to reduce those barriers to help seeking and care and really invest in this population from a prevention standpoint. I just want to lift up some of our work from alumni, Sarah Peitzmeyer, who's now out at Michigan, who really dove into this work in Russia to really understand and unpack the different types of experiences and perpetrators that our sex workers in this cohort were having. There was an assumption at the time that this was primarily coming from police, and it turned out that in this cohort and other spaces as well, it's very much at the partner level and also at the client level, in addition to state actors. So this adds a lot of complexity for us on the violence prevention and response side. But again, if we don't know what we're dealing with, we can't really mount an effective response. And so I've highlighted just a couple of the other places we've been able to unpack some of this work as well. Here as well in Baltimore, in concert with Susan Sherman, many of you know that she runs a fantastic program specific to sex workers in the Baltimore community. And we were able to collaborate to generate some of the first prospective data on, again, violence incidents in this population and, again, that overlapping risk. So I think you can see a similar story here where there's a lot of interaction and overlap among these experiences. And then, again, starting to fill this gap, we've been oftentimes hearing from policymakers and advocates, oh, that violence was in the past. We don't know if we need to take action about it today. Prospective data can really answer that question. The incident rates of violence victimization in this cohort were stunningly high. We had to keep going back to our analyst and also the other data sources because I kept saying, is that really past year? Isn't that lifetime? Isn't that a 10-year period? No, it was past year period. And so this is a really, really, really at-risk population. You can see some movement in and out of risk zones and profiles over this follow-up period. But again, just a really, really important population to be working with. So what's gotten GBV back on the agenda? It fell off a little bit, I think. One of the spotlight things that has happened of late is the COVID-19 pandemic. Really accelerated and expanded the global spotlight on these issues, both in the US and globally as well. And we had an opportunity to really start to test this out and examine the gendered impact on gender violence and also other gender equity issues, specifically in our youth cohort in Nairobi. And this was a really exciting, it's always an exciting endeavor to collect data in a pandemic. Let me say that. Many of you in the room know that well. The bottom line on the gender issues in COVID-19 that we found, and in collaboration with others have been hearing in many of these other examples, is that we really saw these endemic gender differentials that were amplified by the disruption of COVID. So what I mean by that is COVID didn't necessarily bring a lot of new gender inequities, but it did amplify existing ones. When we looked at IPV pre-pandemic, mid, and late pandemic, what we saw very interestingly was sort of movement in and out of safety. So for some people, they had new experiences or sustained experiences of violence. For others, it was actually a time of relative safety. And then for some, when we looked at mid to late, some of that had resolved. Others had transitioned into potentially new relationships and new relationship dynamics. And so the dominant discourse at the time, I think, was that, oh my gosh, we're in a global pandemic. And, we've got a brand new situation of violence happening. That it was true that it really did amplify it. But there was also, again, that movement in and out of safety. Again, something that we can only answer through prospective data. We also had an opportunity, and this was some work, we were so thankful to have some support on this work from the Gates Foundation to really take a broader gender lens on what was going on in the pandemic, coming back to some of the disparity issues that were in the Beijing platform and continue to be inequities today. One of the ones that I'll lift up for you is time use. So you can see the gender differential on time use during the pandemic. This is right around the midpoint of the pandemic, where you see that men's time is going to economic activity. Even in a time of sort of lockdown and COVID-related restrictions, women's time is going to unpaid labor, caregiving, and housework. So again, when we think about an underlying economic disparity, and then we see a gender differential in income generation, we know that we are really experiencing just that combination of new issues and underlying gendered issues in this area. We were able to do a full gender analysis in our cohort in Nairobi for this work. And you can see that some of the risks were gender differentiated. Young men, I showed you the IPV work, young men were really experiencing a lot of police harassment and police violence, often again around transport, mobility restrictions, et cetera. So that was their risk source, primarily in the violence space. We talked about the economic impact. Everyone had an economic impact, but it was magnified for young women. And women also had unique issues around privacy and access to technology that their male counterparts were more able to engage privately and be able to access online resources without some of those restrictions. So when we think about something that sort of affects everyone, a pandemic, we still continue to see these gender disparities. All right, so I'm going to bring us to what can we do? What can we do on GBV? When we really advocate and have honed this 3 pillars approach. Again, our trainees that are in this space know all about our 3 pillars for comprehensive GBV prevention and response. So they are prevention, primary prevention and recurrence prevention, Survivor support. If we haven't prevented, what can we do to intervene early and mitigate impact? And where do we need to be on accountability and access to justice? We can also use our socioecologic framework to guide our thinking and position us in terms of where we want to be on these areas. I lay this out because people often go immediately to prevention or immediately to accountability. And so we really need to be lifting up survivor support within this as well, because it's so important for women's lives and gender equity. So let's talk a little bit about what works in supporting survivors. A robust literature really tells us and has told us over time with very high quality data that disclosing violence and obtaining safety planning and support reduces post-traumatic stress, self-blame, and re-victimization. So this is a time-honored strategy, and it's a well-supported strategy. One of our biggest challenges in public health is that people don't share their experiences, often due to shame, stigma. I'm sure we could add to this list. And those that do often turn first to friends or informal networks. So a core question for our work has been, how do we reach more people with this trauma-informed care and safety planning that we know is actually really effective? So it's an implementation issue. Some of the ways that we've been successful in doing this are bringing trauma-informed care into enhanced GBV screening. So in the early 1980s and 90s, when we were really learning about the health impact of violence, screening in health facilities was really like a fantastic solution for all of this. It turned out it wasn't quite enough to get people connected with care. But what can get people connected with care is integrated, brief, trauma-informed messaging that's embedded in services. We've tested this in Planned Parenthood clinics. We've tested this in mobile street outreach for sex workers and a number of other places. And what I'm happy to say is that this actually really improves knowledge of and connection to GBV-related services, your standard hotlines, crisis counseling, and onward support. It can also enhance perception of provider caring. We found that in our Planned Parenthood clinics through the Project Connect work in concert with Futures Without Violence. And then when we worked on this with our mobile street outreach here in Baltimore City, we found that this actually also improved safety behavior. You see that the difference wasn't so great as it was for knowledge and use of services, but it was a little bit of a signal to tell us we might be able to inspire and bolster safety planning and behavior through this mechanism. So this is a really important strategy. We reviewed some of the GBV prevention and response for HIV key populations. Sex workers, people who inject drugs, and men who have sex with men similarly found that GBV prevention in the context of health promotion was one of the places where we had the strongest evidence. And you can see some really exciting and important sort of practice-based evidence and emergent evidence in this as well. So very much encourage, particularly for trainees, these are places where we need better data and more innovation in study design. So innovation. How can we get safety planning into survivors' hands, even in lower resource settings where services may not exist? One of the solutions that we've been honing over time on this is community partnered technology. And I'm really excited to share with you the work that we've done in this area. A dear colleague who many of you know, Nancy Glass, has really pioneered the MyPlan app, which really helps women reconcile competing priorities and generate personal plans for safety. It's been really effective in higher income settings where abundant resources exist. And we set out several years ago to test out, can this work in Nairobi, where services are very limited, and where use of apps and sort of mobile phones, high connectivity, not as much in the health app space at that time. So we undertook a very extensive formative phase, including tailoring safety strategies and really working with partners on like, how can we do this? Can we do this? Is this a solution? Again, we want to lower the barrier to entry for care. Is this a way to do that? And it turns out that it was. We had a fantastic community partnered trial where we enrolled women experiencing and at risk for violence. We retained them over a follow-up period, and we found that indeed, when they worked through this app together with a community health volunteer outreach worker, they had higher feelings of safety preparedness, and they were using safety strategies that they thought were helpful at a higher rate at the follow-up time period. For women at our highest severity levels of IPV, we also saw increases in resilience, and we saw reductions in risk for lethal violence. So as much as we would want to prevent violence altogether from the very beginning, developing and testing strategies to lower risk and empower people to make their own decisions, survivor-centered care, is really, really important when we look at a full portfolio of how we want to handle this and what are the steps that are necessary to move this forward. I'm happy to say that we are now in a scale phase for this work. We are undertaking a community partner dissemination and implementation trial. Many people have asked us, why not just disseminate the app as much as you can on social media? And we said, you know what, this is actually a tool that we want to institutionalize in health clinics, in chief's offices, in police offices, in CBOs, in community-based outreach. So what we're doing is we're conducting extensive outreach, and you can see we've got a fantastic team. They're reaching organizations. Those organizations are registering in a cohort with us. We're studying their outcomes over time, and they then are engaging survivors, women at risk for or experiencing partner violence. And again, we're tracking their outcomes over time and also the interface between the two. So we're about midway through our data collection for this. Look forward to keeping you posted on this. But again, really thinking about how do we nestle this in systems for maximum impact and sustainability. We don't want this sitting on a shelf. We want this embedded into the culture and into the water so that we can continue to identify and support survivors. I'll give you as well, I want to turn, taking us a little bit further out on our socioecologic framework, but thinking about systems, sharing some new evidence on a long-standing strategy, which is safe housing for IPV survivors. Surprisingly enough, the evidence base on what works in housing is nowhere near as well developed as it needs to be, even though housing is a primary need for partner violence survivors. We were able, with support from National Institute of Justice, to really evaluate transitional housing and also rapid rehousing, graduated rental assistance for partner violence survivors right here in Baltimore City. And we studied women, actually, often we do this at sort of baseline, 6 months, 12 months. We followed them at 3-month intervals, and that's actually really where we saw the most staggering improvements. You see that violence prevalence really plummet in that first 3-month period. And then you see as well, housing instability scores are going down. They went up a little bit near the end of the study, but still a significant improvement for this population. And you can see from our qualitative work as well, these programs are really, really valuable for people. They are keeping them immediately safe, and they are keeping them long-term safe. And we had just a fantastic team of collaborators for this particular study, and looking forward to expanding this a little bit further. This is a place where we have a big role in systems change to make sure that this safety net is functioning and accessible specifically for survivors. What's beautiful about this as well, this doesn't rely on the justice sector at all. This is something that's very, very accessible, even if people choose not to take cases forward through the criminal legal system. And that brings me to the justice pillar. Sometimes this is the elephant in the room. People say to me, don't we have laws against violence against women? And I say, yes, we do. And then I need to point out that violence against women is one of the most underreported crimes, even after VAWA, even after 25 years of Violence Against Women Act. Some of the work that we've been able to do in Baltimore City specifically really looks at intersecting gender and race-related barriers to police engagement in violence against women, minimization of violence against women, discriminatory misconduct, fear of safety, and fear of harm from police.
Miles, let's go.
As
Will you please do me a favor?
we can mute that. People are living busy lives. People are living very busy lives, and I appreciate that. Really important for us to know about the ways in which gender discrimination and gendered systems, and race discrimination and racism and the way that those are baked into our systems, particularly criminal justice, are undermining survivors accessing something that we think should be accessible for everyone, right? So this is really an important piece of the puzzle. Just to take that point home a little bit further, I want to show you the disparities evidence that we have specifically on rape, sexual violence, and intimate partner violence. Not only do we have persistence in these forms of violence against women, we have very profound disparities, and those disparities are being perpetuated again by some of these gaps in justice and also social systems and economic forces, gender wage gap, gender race wage gap. All of these things are contributing to these disparities really being sustained. I'm going to bring us as well on these last few notes to place. So place really matters. Now we're at the macro level. We're at the farthest out layer on our socioecologic framework. Some really important work that was led by Dr. Sharvan Holiday-Norwoo, who is right here with us today, shows us that once survivors come together and come forward for housing, their rehousing is often in more deprived and segregated census tracts in their respective counties. This is generating onward risks for health, safety, economic stability, familial stability, and intergenerational stability. So when we think about this full system, we need to be thinking about concentrated disadvantage and the ways in which it interacts with other forms of hazard. I'm going to keep us moving because I know I want to have a little bit of time for questions. Place matters in policy. Place matters in policy and social context as well. Our colleague Anais Williams, who is also right here, is heading up some secondary analysis of the DHS data, which again is allowing us to see patterns of prevalence of violence against women and really looking at the impact of a number of our national indices. We have indices now on economic participation, on the quality of laws and the legal framework that exists to support and protect women's rights, as well as the legal climate on the quality of the laws on violence against women. How strong are they? What is the legal framework that is in place? So we can really evaluate the policy context and compare prevalence across sites, which we've had a chance to do. The heat map that you're seeing is a chance for us to see how well are those policy and social climates functioning at different levels of household wealth. Is this lifting all ships? Is this tide lifting all ships? And what we're seeing here in the green is that I'm going to bring you to the far right and the lowest element here. The laws against violence against women and the strength of those laws is functional, but it's most functional, it's most protective for women at the highest household wealth levels. And we're not seeing the impact that we would like to see at the lowest levels of household wealth. That's a big problem. That's a really big problem. Something is going wrong there. And then when we look at the economic participation indices as well as the legal climate, that's actually where we see the most protective effect for women at the lowest household levels. So there's a lot here to think about and unpack, and we won't get into all of it today. But the point for us is that, yes, policy really matters, but we shouldn't assume that we're reaching everybody through those policies, and we need to be really looking at a much more granular level to understand where more work needs to happen, and also what can we learn? What's working well up here? What's working well so that we can bring and lift those social determinants and really bring everyone into that equity space. So a couple last points on place. Place matters. Place matters. Probably some of the most exciting work that we are undertaking right now is really looking at the macro and basically the interface of the macro and the micro environment. So there's been widespread interest in looking at social and physical environments for GBV prevention, so much so that it came out as a strategy from the CDC in the Stop Sexual Violence Technical Package. There's a lot less clarity on how to do this well. A lot of folks are going to sort of a focus group approach to determine which places are the riskiest. There's a lot of risk for bias within that, and there's a lot of underutilization of existing data sources. So together with colleagues from Maryland Coalition Against Sexual Assault, Department of Public Health, and a whole host of collaborating institutions, we're starting to really look at the microenvironment, running some ecological momentary assessment, short survey bursts to understand what's happening right now, who's in the environment, what are the hazards, what's going on, so that we can begin to move us away from sort of this blanket like who's at risk to where is risk happening, in what environments, with whom, what are the opportunities for prevention at the micro level, and what are the greatest risks at the micro level. So stay tuned on that. We've run our feasibility pilot and getting pieces and approvals to do this work specifically in GBV is an undertaking. And so it's been a really exciting piece of what we're doing. We're also looking to understand some of the latent profiles of GBV experiences, again, because we need more precision. We're not in the 90s anymore. We have really high quality data. We can differentiate these and really take action so that we can really best position our prevention efforts. One of the most exciting things about this is that we're also developing how-to guides for campus partners. Campuses are tasked with create an incredible array of data collection and maintenance. Campus security reports, campus climate surveys, which are federally mandated every 2 years. This is a wealth of data for people to work with and unpack so that they can really have an evidence-based solution. But it turns out that a lot of campuses don't totally know how to do that or don't have the infrastructure in place. So that's part of what we're doing in collaboration with MCASA and others to really help people use their own data to generate those local solutions. So stay tuned on this. This is a really exciting sort of next step in all of this work. So the last couple of places that I want to bring our attention to are very much about community partnerships. The work that's done in the school, even in collaboration with other research partners or CBOs, is never going to serve its purpose if it's sitting in the shelves of our libraries or sitting on the shelf somewhere. So getting this out into the hands of stakeholders, policy audiences, and grassroots mobilizers, many of the same people who attended who really created the Beijing platform, for example. We need data to be accessible and in the hands of activists and practitioners so that we can use this evidence to create change. Our team, I'm thankful to have worked with an incredible array of colleagues, many of whom are in the room and on Zoom, and really generating, whether it's briefs for lay professionals. Our colleagues at ICRHK have been fantastic in drawing media attention, including national televised results distribution. That's really bringing these conversations to the kitchen table and to the water fountains and to other places where we can really generate change. A lot of this work as well is hand in hand with CBO partners. So you can see our mapping exercises, some of the ways in which we're really working with community partners to understand what are the risks in real time, what are the key priorities, because this work isn't useful if it's only coming from the academic side. This has to be in collaboration with community, really so that we can create that impact. We were also really excited and thankful to have the Stoop storytellers work up some stories with our Nairobi youth cohort. Really a way to, again, get people engaged and excited about this work. All right. This brings me to the path ahead. Our data innovations, as you've seen, have really taken us a long way in this work. We don't have a single solution for gender-based violence as of right this second. We have a mandate to create effective layers of solutions, much in the way that we needed to do for COVID. The Swiss cheese approach is relevant here, right? We need action at the ed level. We need action at the systems level and housing. We need economic parity, and we need a number of strategies to get people connected to survivor supports and care. What we do have is an evidence base to take action, and we're ready to stop pretending that we don't know how to do that. We're ready to really move this into the next generation of prevention and response, ready to really scale this work. And so when I look ahead, I see that we're fully in 2.0. The last decades were really on prevalence and risk factors. Now we are on what works, for whom, where, and how. And let's make sure that we're lifting up those that are most vulnerable within that. What's got me fired up on this right now? We've got our What Works collaborative to prevent violence against women. This is a major investment from FCDO. Huge consortium partners, both on the implementation side and the research side, which Hopkins is part of. So over the next 7 years, we're going to be investing in and really running a whole host of prevention and evaluation studies to really hone our understanding of what works in this space. We have an executive order from 2021 on establishing a White House Gender Policy Council tasked with creating our first ever national action plan for gender-based violence that is coming out any day now. I'm really ready to see what systems changes we can create and monitor and push us forward through this executive order and through the White House Gender Policy Council. We have generation equality, which is fulfilling the promise. Any of the unmet asks from the Beijing platform are really the task of generation equality. And so this is infusing some new life into this movement and is really creating, again, that platform for moving us forward into the next generation. And finally, right here at Hopkins, that's the U factor, and U Online as well. We've got always new training coming up. We've just gotten our DBV course in the new Gender and Health Summer Institute, along with an incredible set of colleagues and collaborators here at the school. Shannon Wood is leading the women's health class. Rosemary Morgan is leading our gender analysis class for that. And so we've got a really great lineup in that Summer Institute. So that's the U factor. So I leave us on a note of optimism for this work as we move forward, and thrilled to see the next generation and the current generation of trainees in this space, and certainly just want to really, I embarrassingly ran out of space on this slide. There are so many people to thank and so many amazing collaborators here at the school, globally, all of our CBO partners and our entire team. This work takes really a village. And you've seen a snapshot of it, and you're the village, and that's why we're here. So, thank you. Okay.
Thank you so much.
I left enough time.
Michele, yeah, so we have some time for questions. Becky is going to, we have time for questions or comments both from in the room and also online. And I just want to take this moment also to invite all of you to the reception on behalf of Michele in the gallery afterwards. So take it away.
Thank you.
Thank you. Michele, that was absolutely wonderful and so fitting for International Women's Day. As I was drinking my coffee this morning, I was listening to a summary of a report indicating that some of the gender-associated wage loss, job loss, it's still happening. And this was in light of what today is to really make this point that around the globe, that the losses that were incurred during the pandemic, specifically for women, have maintained. And so I'm wondering, in light of you showing us this association between that economic insecurity for women and gender-based violence, you know, are we still seeing the losses in progress in gender-based violence? Are we still seeing that uptick that was observed during the pandemic be maintained?
Yeah, thank you so much for that. It's such a great question. And I think it's the question of the day on gender equity and also pandemic recovery is for how long are we going to see this blip, right? So, you know, in many aspects of life, we've gotten some normalcy back. But I think that when we look at the blip that we're seeing on wage loss, job loss, economic losses, basically, and the gender differential, I think we're going to be seeing that for some time to come because it was so very disruptive. Women exiting the workforce, and this is why having that historic lens is so important, because we need to not think about that as something that's sort of parachuted in. We need to remember that before that, we had a gender wage gap. and we've had it for a long time. And we have a gender race wage gap, and we've had that for a long time. So we can't pretend that this parachuted in and then is going to be a quick recovery. And I'm not trying to be a doomsday person. We all know I'm a relentless optimist. But what we need to do is be very honest about the conditions that we're working against and the level of investment that it's going to take to right this ship.
Thank you for the wonderful presentation. I was wondering, what role does having like a role model, whether it be in the community, in your family, or even a celebrity that might have escaped like an abusive relationship, empower other women to seek out care or
Yeah. Great question. What is the value of seeing others survive and thrive in adversity, including in GBV situations? One of the things that I immediately went to in my mind when you were asking your question was about the element of isolation that people experience when they've had an experience or a chronic set of experiences that are stigmatized, shamed, and ostracized. Part of that is an isolation factor. And so when we see people breaking the silence on this, sharing their stories, certainly we could talk for hours about the whole Me Too movement. That gives people some inspiration, yes, but it also breaks their isolation. People that are seeking to silence the voices of survivors are often actively telling people to be silenced. Don't tell anyone about this. You'll get in trouble. You'll be blamed. And so it's an active tool. It's a perpetrator tactic, and it's reinforced by the whole social system. And so I'm really glad that you raised that, because I think that really is helping us see and understand the role that, right, a friend or some sort of role model or even a celebrity that you have never met can start to break that isolation. And I think that's part of the conversation that Me Too really opened up. Yeah. Oh, thanks.
Hi, Dr. Decker. We have a question from someone online. The question is, do you see a role for AI in GBV research, evaluation, and practice?
Oh, great question. I love that. So, the tech, I haven't seen that in practice just yet. The question is about AI. But I can say that the quality of our ability to harness tech for research, prevention, response, and even unpacking stigma is actually really, really, really exciting. And that's absolutely part of the next generation on this, certainly in this work. Yeah. Yeah, go ahead.
We have another question from someone online. Ananya, would you like to unmute your mic? Ask your question?
Yeah, thank you. Thank you so much for your presentation. I think it was really eye-opening to see like the compounding effects of how so many different levels can interact. And I guess I was wondering, in communities and environments where the social norms are homogenous in I guess in an almost like a bad way, in which like people don't feel comfortable recognizing that gender-based violence is happening, or like rather than like this is the norm. And especially when you're working in resource limited environments where maybe you can't access smartphones or use disruptive technologies to open up that space, how do you work toward shifting the social norms when like the opportunity to create that initial change maker is the threshold is much higher?
Okay, right. What's step one in an environment that is restrictive, I think is kind of what you're getting at. To be honest, the guiding principles are very carefully in partnership with community partners, but this is also a role for evidence, right? This is a role for evidence in terms of like, how do we unpack and explain what we're seeing? When we bring the DHS data or we bring national survey results to a specific community, folks that are in my class know that actually when doing the Project Connect work, I brought the study results to our Planned Parenthood clinic partners, and I said I was kind of running through the demographics. I wanted to get to the impact of the intervention, but I was running through the demographics, and I said, and this is the prevalence of violence in the population and clinic population. Kept on going, and they were like, wait a minute. They're like, can you go back to slide 8? I said, sure. Go back to slide 8. I'm thinking, what's on slide 8? Slide 8 had the IPV prevalence in their clinic population, and they were like, oh my gosh, they couldn't believe it was as high as it was. And as an investigator, I had, run the numbers, looked at the data, and I was like, yep, that's basically what the national prevalence is. But the national prevalence was not relevant at all to their thinking about the topic. And through no fault of their own. It just, they weren't seeing it in their day-to-day. They weren't seeing it. And so then when they saw it with new eyes. And so being able to have a conversation like that really sometimes is very much the starting point. It was an aha moment for everyone in that room, myself included. And it really sparked a new investment and motivation for addressing the issue because it was felt to be suddenly the spotlight was, oh my gosh, these are our patients. And I think that the example and the question that you're raising, and thank you so much for that, Ananya, is very much as well relevant on that in terms of how do we understand, how do we quantify and count and then understand the experiences that we're having, and how do we start to think about the ways in which gender relations, women's rights might be working or not working. I can tell you that I've led and been in a lot of those conversations, including in environments where people have warned me, this is kind of a hostile environment on this topic. And time and again, it has been so inspiring and exciting to me to see that when you start asking those questions, people quickly start opening up. It has never been as daunting as perhaps we feared that it might be. So it's important to remember and approach those situations with caution, but also with optimism, because those dialogues really can create and be the seeds of change that allow us to keep this work moving forward. Yeah, thanks.
So I think it is time to thank and congratulate Professor Decker once again. Thank you. And to move this conversation into the reception. So thank you all so much for coming. Thank you so much, Michele, for your wonderful work.
Thank you.
Congratulations.
Thank you. Thank you so much.